Alrighty, guys, let's go ahead and get started for today. My name is Alex Ruiz. I am the Director of Content and Community here at Paloma Health, where we specialize and focus on treating hypothyroidism and Hashimoto's. We are a full service virtual online medical practice. So, all of our providers, like our guest here today, Dr. Heather Krantz, can fully see you from the comfort of your own home. We can treat Hashimoto's and hypothyroidism if you need medication refills and all of that. But we're much more than that. We also have an app that can help you navigate through AIP, for example, if that's something that you are interested in doing or navigating or feel like that might be the next step in your journey. But a lot of our providers, obviously walk that line with you. They, will help you kind of figure out a supplement protocol, what lifestyle changes you need to implement. And we also have a nutritionist on staff that can help you with any sort of like meal planning or anything that you have. If you haven't checked out the app, go ahead and download it on iOS and Android. And you can do a lot of different things. Honestly, it has a lot of cool functionality. You can symptom track, which is honestly our biggest thing. A lot of people are super grateful for that. So you can really see the progression that you're making as far as the improvement of your symptoms. You can do medication reminders, which honestly for me is a lifesaver because, quite frankly, with brain fog, you just forget sometimes. So lots of cool things. Again, meal plans. If you just need like meal ideas for the family, for yourself, whatever in general, again, even if you're navigating AIP or just need maybe some paleo-friendly options, or let's say, you don't tolerate eggs well, for example, that might be an option for you. Those are all available on our app and on our website, which is full of blogs, resources, past speaker series, just like the one you're attending today, and so on and so forth. So without further ado, we're going to go ahead and get started for today's event, which is hypothyroidism, PMS, and Peri-Menopause, which I'm so excited to connect with, again, Dr. Heather Krantz. She's one of our providers here at Paloma Health, and the one and only Mary Shomon, who is our go-to thyroid expert of all the things. So just a little bit about Dr. Krantz. She is a double board certified in gynecology and integrative medicine. And she completed her medical degree, internship, and residency at the University of Kansas. So without further ado, Dr. Krantz, why don't you tell us a little bit more about yourself?
Thank you, Alex. Yes, I did all my stuff in Kansas and then promptly left after I was done. So it's great to be here. Thank you for having this forum right now. It's of quite a bit of interest to me, obviously, as an OBGYN. So, I trained as an OBGYN. It's been, 30 something years. So most of my career has been dealing with women's healthcare and, dealing with women in general. And that's really been my focus. And the thing about women is, the three of us and everybody probably watching knows, is, we're pretty attuned to our healthcare and we're pretty self-aware. And we also tend to be the decision makers in our family about medical care. So, women started coming to me with ideas about using alternative things, I don't know, probably 20 years ago, 25 years ago. And it kind of piqued my interest in integrative medicine. I realized that I had some gaps in my knowledge. So that's when I kind of pursued doing an integrative medicine fellowship, which really kind of blew my mind in a way. It was a whole different way of looking at medicine that I didn't really learn in medical school. It was more positive and holistic and without the disease emphasis, and very much kind of like Paloma's approach, which is partly why I'm attracted to Paloma. Best of all, I think that integrative medicine and even my own tendencies, and I know most of the doctors at Paloma feel this way. It's more like it emphasizes like a collaborative partnership with patients. Where the partner and the physician are kind of working through this all together to solve the puzzle of kind of what's going to work for that patient. And that's, why I'm interested in all this. I really enjoy that collaboration. I really enjoy kind of making that bond with the patient and working through it, because it's not like a one size fits all kind of thing. It's not like, traditionally in medicine, here, take this medication, it'll fix your problem, go away kind of thing. And, just a little bit of addition about myself. I mean, as why I'm interested in the thyroid care, and I know both of you guys have the same kind of thing, is because not only was I interested in integrative medicine, but then, of course, then I got diagnosed with Hashimoto's, and that drew me to it even more. And even beyond that, I really had a frustrating process. Even though I knew all this stuff, it was frustrating because I still have to deal with a doctor, even if they're my colleague. And so it really drew me kind of into, well, this is stupid. Like, how can I help this work better? Because my colleagues were saying the same things that you guys have all heard, is well, just take this medication, or why do you need to know that test result? That doesn't matter, those kinds of things. So that's kind of why I've really developed an interest in thyroid care. Is it's the most common problem for women, one of the most common problems. So that's my story.
Well, I think that perfectly segues into why Mary does what she does. But then also I love that I think this is the perfect timing because, Women's History Month, it starts tomorrow officially. And as since Hashimoto's and hypothyroidism is predominantly prevalent in women, I think you kind of hit the nail on the head that it's just something that unfortunately majority of women are going to have to deal with in today's society in modern times. And how are we bringing awareness and advocacy? And so with that being said, introducing the one and only Mary Shomon. For those that don't know, Mary is a huge, huge part of our team here at Paloma, and she really helps just guide so much of the amazing content that you guys see on a daily basis. So again, just so many props to Mary, but she's more than that. She has been, like I said, a longtime advocate, one who's really been spearheading so much change and just awareness within the space. She is an author. She does all the things. She's an author, an advocate. She, sees clients and everything. She's a consultant. So she is the Jill of all trades. So without further ado, Mary, tell us more about you and how you got started into the thyroid space and kind of your story.
Well, thank you, Alex. That's quite an introduction. I am almost 30 years into this advocacy thing. I was diagnosed with a thyroid condition in the early 90s. And I think it was 94. So I'm coming up right on the 30th year here. And at that time, it was the old days of the AOL dial-up disc. Alex, you probably don't even remember those. Heather might. But the internet was in its infancy. And I went to the library to find out about my thyroid because my doctor said, I think your thyroid is slow. So I went to the library. They had one book. I don't remember what it was called, but in my mind, the book is called Your Thyroid, the Least Important Gland in Your Body by middle-aged male doctor, MD. And that obviously didn't help me very much, that book. And I started trying to find out other resources. And I ended up on the internet in its very early days, trying to connect, finding some Usenet support groups, the earliest forms of forums and communities, and started to connect with other people. And I discovered that I was not the only person who didn't really understand my thyroid condition and who wasn't feeling well on the just take this pill and come back in 6 months or a year program. And long story short, that led to my creating a website, staying up all night and learning HTML, and then creating a little website, which then I ended up moving over to a site that became about.com, which then got bought by the New York Times. And I ended up with like one of the biggest thyroid specific websites on the internet, and wrote a book then because people said, well, the internet's great, but there's still a lot of people who don't have web access. So at that point, I wrote my first book on thyroid. I had written several other books, but I wrote my first thyroid book called Living Well with Hypothyroidism. And I was off to the races. So I've written about 15 books about different aspects of thyroid health, autoimmune disease, and overlooked types of conditions like fibromyalgia, chronic fatigue syndrome. And as you mentioned, since then also I write, I create programs, I do some patient educational coaching. And, some people call me the Norma Ray of the thyroid world because I'm out there, yelling and pushing and really trying to do what I can to keep patients at the forefront of thyroid care. And my philosophy is, however we can, our job is to fast forward you up the learning curve to get to the good part, which is the part where you start feeling well. So that's my motto. And as far as our topic today, I have been through all of it. I've got Hashimoto's, I've got hypothyroidism, I've had many years of PMS, and I went through perimenopause. So been there, done that, and ready to talk about it. So.
Well, yeah, thank you ladies for joining me today. And again, I just feel like it's so important having that blend of just somebody who's been through it from the advocacy patient standpoint, and then obviously having someone like you, Dr. Krantz, who not only is the patient, but has also specialized in this area, which I think is a really beautiful, just kind of insight that you don't get a lot of times from providers. And quite frankly, I feel like a lot of patients can honestly trust doctors more when they understand the condition in that way. And it's unfortunate that even you, for example, had to experience it firsthand to realize, oh no, this is a problem and I'm going to do something about it. So thank you for doing something about it and being being here.
Yeah, can I mean, I have to interject that, kudos to Mary, because I have your books too, Mary. And I've been following Mary for years, and it really does make a difference. And it's kind of piqued my interest further, looking into those books. So thank you.
Thank you.
Well, as you guys can see, we have two amazing ladies here to give you all the information. So why don't we just go ahead and jump right into it? Heather,
yeah,
as the expert here, what is PMS? Why does it happen? Is having PMS symptoms normal? Can you kind of just explain this whole process?
Okay. So what is PMS? So PMS, a simple definition would really be like physical and psychological / emotional symptoms that some women get basically after ovulation, the last 2 weeks of the cycle before the period starts. So what's called the luteal phase. The cycle, you have to remember that physicians, and I know this is a little bit strange, but physicians define your cycle as starting with your period. Because I know most women think of that as an endpoint, but hormonally speaking, that's not really the endpoint. Hormonally speaking, when your period starts, that's the follicular phase. And then you ovulate in the middle of your cycle, and then that's the luteal phase. So really PMS is, that second half of the cycle. Why does this happen? That's a good question. Honestly, we don't really understand it. We think that it happens because of fluctuations in hormone levels, basically estrogen and progesterone. We don't totally understand kind of how this works. We know that estrogen and progesterone receptors are really throughout women's bodies, and throughout all the organ systems in the body. It's kind of like thyroid hormone as well. But that means that it really affects everything and has an influence on everything. So those fluctuations or changes in hormones really can influence how you're feeling, what physical symptoms you have, what emotional symptoms you have. For instance, I think most women realize that we can attribute certain symptoms to progesterone, for instance. Progesterone is kind of the hormone you would think of, is the culprit for things like bloating and, water retention and that kind of stuff. But that's obviously not the whole story. That's just a piece of it. What else? So is it normal? It is normal, honestly. PMS is really common, but there's a qualification there. I have to put a caveat on that. It really varies. It varies from some women get no symptoms or really mild symptoms to, extreme severe symptoms. So really, the type of symptoms that women get varies between women. Some people get mostly physical stuff. Maybe it's bloating or breast tenderness or, constipation, diarrhea, GI stuff, cramps, headaches, or other women might get more emotional or psychological stuff, like they might feel irritable or fatigued or have sleep issues, appetite stuff, memory problems, libido stuff, problems. They might feel depressed or just, sad, those kinds of things. It really just depends on the person, what you get. Another thing about PMS that's important to understand, which kind of goes with our other piece of our topic, is that it tends to get worse as you get older. It tends to get worse as you go into perimenopause, which obviously we're going to talk about. PMS, while I'm saying it's normal, it really is a matter of degree. If it adversely affects your daily life, your work, your relationships, just living through the day every day, then that's a problem, and that's when we start really addressing it. What else would you like to know, Alex?
I know. I'm like, so I think the biggest thing here is, kind of like with Hashimoto's and hypothyroidism, everybody's symptoms are going to vary.
Right.
For some women, like you said, they're going to experience, I know for me personally, I experienced a lot of cramping, bloating. My weight, for example, would always fluctuate right before my period. And that was something that I always struggle with. I didn't really struggle too much with something emotional, but for some women, unfortunately, they may, be, let's say, a little bit more depressed in session. I think that's why just a personalized individual approach to everything is so important. Mary, kind of segueing into that, can you tell me about like having Hashimoto's, and is that a greater risk for experiencing PMS? I know that our sex hormones can heavily impact our thyroid hormones and kind of vice versa, right? And work in conjunction with our thyroid hormones. Like, can you speak kind of to like the risk and I guess the associations that you're more likely to experience because you have Hashimoto's, or are you likely to experience Hashimoto's because, let's say, your sex hormones are completely off?
Mm-hmm. Sure. Well, I mean, there's a fairly decent body of evidence that anytime we have an endocrine disorder, it is going to increase our risk of destabilizing the endocrine system in general. So women with Hashimoto's and hypothyroidism do tend to, in some studies that have shown that they have harder PMS, they're at a higher risk of PMS. But as Heather pointed out, that can vary too within individuals, because there's going to be some women, even with Hashimoto's and hypothyroidism, who are going to have fairly mild PMS symptoms. Others are going to be extremely intense, and you don't have to have Hashimoto's or hypothyroidism in order to have any range of symptoms as far as PMS. But generally, when we're looking at the hormones being unbalanced in the thyroid, and that oftentimes comes along with some adrenal imbalances, and then we can also see some shifts in that estrogen and progesterone. The other thing is, and I think we can probably get Heather to jump in too to talk a little bit more about this, but estrogen and progesterone, estrogen and thyroid are very connected in many ways. And so when we are, for example, estrogen dominant, when we have too much estrogen, that can in some cases affect our thyroid negatively. So there's a variety of different ways that there's an interplay here. But I think that the general gist of it is that we need to look at the range of symptoms that we're experiencing, how it relates to our hormonal balance uniquely. Because in some cases, a woman with hypothyroidism, her symptoms, her perception of her PMS, and later we're going to talk about perimenopause, may in fact also be connected to the fact that her thyroid treatment is not sufficient, because some of those symptoms are crossover. You got fatigue, you have brain fog, you have low mood, you have a lot of symptoms of undertreated hypothyroidism that are also the same symptoms of PMS, and they're the same symptoms of perimenopause. So Heather, I'm going to see if you want to jump in on here and add anything.
No, I totally agree with you, Mary. I think that, as you're saying, and the systems are very intertwined. And not only are they intertwined, it's that, I'm constantly telling patients it's hard to see the forest for the trees, basically, because the symptoms are so similar via PMS, perimenopause, which we'll talk about, and thyroid symptoms. And sometimes you don't know which thing's coming from which place. Exactly. So it's sort of this whack-a-mole kind of approach to things where you have to let's try to balance your thyroid hormones as best we can and see if that helps, and then you can talk about your female hormone levels, and how can we balance things there, or what approaches can we do there that will help to balance things there. And it's really frustrating, I think, for patients, because they kind of want it all at once. Everybody does. Who doesn't? I want things fixed. I can think of a patient I had recently who was sort of in that perimenopause zone, and we fixed all the thyroid stuff, and she came back, she's like, oh, I guess my menopause is over. And I'm like, not really. It's just that it was those symptoms, not the ones you thought it was. Exactly. So yeah, I mean, I guess that's why I enjoy this so much. It's like a big puzzle, and that's why you enjoy it. I'm sure it's a big
Mhm.
puzzle, and you're like, well, let's try this piece and this piece, and as you fit them all together, a picture emerges, and hopefully that picture is better well-being for the patient, because that's the goal.
Yeah, I definitely think, well, I mean, we know that the thyroid just affects so much in general. And I think that's just another reason what you guys mentioned exactly of, you know, getting your thyroid to an optimal place, because a lot of symptoms may subside. You know, we know that there's a heavy correlation with the misdiagnosis, for example, with depression and all these like mental health conditions that are also related with our thyroid. And the same thing goes with, you know, unfortunately, hormonal sexual health based conditions as well, where, you know, if we can get to our thyroid to an optimal place, hopefully these symptoms not will not always subside, but there's a potential that they can completely. And it was just something that, you know, was kind of letting us know that something else was kind of going off in the body. Heather, you know, how do we you talked about, like, you know, the correlation obviously here with your thyroid and it affecting, or at least drastically making your PMS experience worse. There are unfortunately some women that experience PMDD, which is premenstrual dysmorphic. I always butcher this, sorry. Dysmorphic disorder. I always butcher it. How does this exactly differ from PMS, and how do, I guess, women know the difference between the two? Because, you know, for a lot of women, that this is just, this is my period. You know, I think a lot of times, especially like women's grandmothers and great grandmothers, it's like, this is just what happens every month. You know, it's totally normal, and you just suck it up and get a hot heating pad and all the things. But I guess, you know, to answer the question is, how do you know the difference between PMDD, PMS, or, you know, at what point do you realize, like, no, this is actually severe and we need to do something or look further into it?
So that's a great question, because PMS and PMDD kind of exist on a spectrum. Okay. You know, it's an interesting thing, because most OBGYNs don't really use the term PMDD very much, honestly. It's actually a DSM-5 term, which is the Diagnostic and Statistical Manual for Mental Health, which, quite frankly, I find a little offensive that they put this, you know, as a diagnosis, as basically a psych diagnosis. You know, most OBGYNs would look at it as extreme PMS, and that's really what PMDD is. You know, it's the extreme version of PMS. You know, there's certain criteria that you have to fulfill to, quote unquote, be diagnosed with PMDD technically, but every woman knows what PMS is, and every woman can understand what extreme is. It's really what I mentioned earlier, which is, when is it so bad that it's really messing with your life? Like, it's messing with your relationships, you're angry all the time, or you're failing at work or school because of it. That's when it really ends up being PMDD. I mean, yes, you can go through the criteria, but honestly, as a physician, if a patient comes to see me and they're like distressed and it's really messing with their life quite a bit, I'm not going to go through those criteria. I don't care, honestly. You know, it really, I need to help them fix the problem. I need to help address the problem. I don't care whether the diagnosis fits perfectly. You're nodding like crazy, Mary.
Yeah. Oh, absolutely. Absolutely. Because, you know, I can relate to all of the symptoms. I mean, I had all of them. And I have family and friends that have had variations on it too. I mean, some people, you know, that really sail through, their PMS period, and others that literally they're so laid out from the pain and, you know, migraine. They get intense migraine that accompanies their PMS, and everything goes haywire. So I really do feel like, I appreciate your approach, Heather, in saying, I take it seriously. If it's getting in the middle of your ability to function, and as far as I'm concerned with PMS, if it can't be solved with a steak and chocolate, which were my two go-tos for PMS, if that isn't going to fix it, then we've got to take a look at this.
Right. And the other piece of it, there's like a diagnostic burden there. Basically, if you have to, fulfill the diagnostic criteria, basically, which basically is like you have to have 5 symptoms, plus you have to have a mood issue, plus you have to have one of these other things like apathy or sleep problems or fatigue, then it's like, really? I mean, I'm sorry. What if it's just I have really horrible migraines and terrible insomnia? You have a problem. It's affecting your life.
Exactly.
Maybe it's not technically a psychiatric diagnosis, but I don't think any of us really care about that piece of it. It's still severe PMS, basically.
Mm-hmm.
I mean, I think that also speaks to how like thyroid care is done and the problem that we're seeing right within just endocrinology and just thyroid care in general is people, maybe only come in with extreme fatigue and that's the only thing. And they're like, well, are you getting 8 hours of sleep? Okay, well, no, then that's the only problem. And it's like, yes, that is true and a priority. But at the same time, like just because I'm not experiencing all the other classic symptoms such as joint pain, like you said, fatigue, depression, all the things, that doesn't mean that my fatigue only experience is not valid and or indicative of a potential thyroid condition. I think that speaks to the same thing with, just in general, what we're experiencing from a PMS standpoint. Just because you only experience one thing doesn't mean that you're not, quote unquote, you don't have it just because of the diagnosis and you need to meet all these other check boxes. And I think when we get to a point where overall doctors are basing their care based on symptoms and how patients are feeling versus just checking this box, we'll get to a better place in general with care. And, like you said, addressing the symptoms now, there's no point in waiting for a diagnosis or for something to get worse when we can be as preventative as possible. And okay, well, what are you experiencing now? What can we do now to help alleviate that, both just from, like you said, a PMS perspective, but then also from a thyroid perspective and the symptoms they're actually experiencing. Mary, you mentioned you went through perimenopause and experienced all the things. Tell us, what is perimenopause? Because, we obviously know that within just the female life cycle, you go through your fertile years and then you go through your perimenopause, and it's a domino effect into menopause. And we do have a speaker series if you would like to see more or learn more about menopause in general and its impact on your thyroid health. But I feel like a lot of people don't really talk about perimenopause, which is still so important, because one, how does that differ from menopause, and where is your body at in general? But that still can have such a profound effect on your thyroid health, but also what you can likely experience during menopause as well, and ways that we can set ourselves up for success. So
absolutely.
Yeah. What's kind of the situation there, I guess you can say.
Here's the interesting thing about perimenopause and menopause, the terminology, because a lot of people use them interchangeably. Yeah. When you hear the words menopause symptoms, they really are, in most ways, the symptoms of perimenopause. A lot of women, once they reach menopause, and let's talk about menopause, is defined as the point at which it has been a full year since your last menstrual period. So by the time you are officially menopausal, you're done with a lot of the up and down. Now, not every woman is going to have no symptoms at that point, but some women will find once they have reached that stage, things calm down. It's the time before the end of the menstrual period where the chaos happens, and that's the perimenopause. And when I was starting to go through my perimenopause, I was actually writing a book on menopause and thyroid. And I really didn't know that much about menopause. I was really starting out, as an advocate, to really learn a lot more about it. And honestly, I really thought menopause at that stage, I was ignorant about it. I thought it was like a Golden Girls episode where you have some hot flashes for a couple of days and you feel a little out of it. And then a couple, 2-3 months later, it's over. I didn't realize that for some women, perimenopause and all the laundry list of symptoms, which I'll run through in a second, can start as early as your late 30s. Totally. And it can go, in some women, the average length or the median length of perimenopause is about 4 to 5 years. The average age of menopause, so you've had your last period and it's been a full year, is 51 in the United States. So that would put most women having their last period around 50 on average. But that means then that there are women that are going into perimenopause at 45, but there are also women that go into it in their late 30s and have an earlier menopause. And then there's some women who just have perimenopause for an entire decade. So if you don't know you are in perimenopause, but you are in it, you are lucky. Go buy a lottery ticket, because most women who are in perimenopause, they know it. The way that you know, first of all, the one most classic sign, erratic periods. You might have short cycles. You might have long cycles. You might have heavier flow. You might have lighter flow. You may have missed periods entirely. You might notice a change in the color or the quantity of your flow. You may have clots. You're going to see all sorts of changes in your cycle. That's often one of the earliest signs of perimenopause, are these shifts in your cycles. This is due to, in some cases, anovulatory cycles, cycles where you don't ovulate, or shifts in those hormones where we're going into some imbalances there. And keep in mind that when you have a thyroid issue, the risk of perimenopausal symptoms is significantly greater. There have actually been studies that have shown that having hypothyroidism increases your risk of having perimenopausal symptoms. And if you have Hashimoto's, that's even more of a risk factor. So the likelihood that some of us are going to have some perimenopausal symptoms as we head into our late 30s, early 40s and beyond are pretty high. But those irregular periods are quite common. The vasomotor symptoms, these are the ones that everybody associates. They think of menopause, but it's the hot flashes, it's the night sweats, it's that body buzzing, those internal tremors and feelings of like electric shock sensations, and crawly skin, dry skin, paresthesias. I have an interesting tip. There was a study that found that for women with Hashimoto's and hypothyroidism, one of the vasomotor symptoms, some women will have hot flashes, but some women who have Hashis and hypo, they actually have cold flashes, periods where they feel extremely cold. Their hands and feet will feel cold, and then they sort of pass. And it's apparently a vasomotor symptom, much like a hot flash, but it's more common in women with Hashis and hypo. So, you know, anything goes in some cases with these types of symptoms. We have sleep problems. Insomnia is very common. Early waking, frequent waking. Fatigue and exhaustion are common in perimenopause. Mood changes. So all of these things that we saw in the PMS, as Heather said, you know, the PMS tends to get worse as you go, and then it can oftentimes start morphing into these perimenopausal types of symptoms. We see mood changes, irritability, anxiety, rapid mood changes. 1 minute I'm crying, 1 minute I'm laughing. New addition to the list at this point are vaginal problems. We start to see vaginal dryness, lack of lubrication, sometimes painful intercourse, increased risk of vaginal infections starts to come into play. We can also see bladder problems in women into perimenopause as they approach towards the menopause. That increased risk of urinary or bladder infections, incontinence in some cases. Libido, sex drive can drop. We can have, as we get further and further along, bone health problems, issues with our bones maybe becoming a little bit thinner. Cognitive issues, one of those big granddaddies. It's a PMS problem, it's a thyroid problem, it's a perimenopause problem. What's making it worse when I have brain fog, difficulty concentrating, memory problems? Yeah. You can also have some bloating, weight gain. One characteristic of perimenopause and menopause is a shift of body weight from the belly and people will get into their hips, their thighs, their rear end. It sort of tends to concentrate all in the central area, abdomen, hips, and buttocks. And then there's other symptoms of perimenopause too: breast tenderness, headaches. Some women get achy joint and muscle aches. Hair can fall out. Skin can get dry. So there's almost nothing that's not affected in some way by perimenopause.
But also, it's this is so it's kind of comical that it's just like all of the things people with thyroid conditions also struggle with. So it's like, what is it? Is it, you know, my sex hormones, or is it my thyroid? Like, how do we rule this out?
Well, I mean, a good doctor like Heather is going to, you know, if a woman comes in with a laundry list of those symptoms, I'm guessing she's going to run a thyroid test. Heather, what do you think?
Well, yeah, and it's also like the approach is very, you know, stepwise, you know, in terms of, you know, once you have the diagnosis about thyroid stuff, then which symptoms are from which thing, and you may never really know, honestly. It's more just how can you address it to help the patient feel better.
Right. Heather, we talked about, obviously, when you have a thyroid condition, you can potentially have irregular menstrual periods. A lot of women struggle with estrogen dominance and all the things. And obviously, those are also irregular periods, a classic sign of perimenopause as well, where you haven't had a consistent period, let's say, over the course of a year. But how does having an irregular menstrual period or significant hormonal imbalances affect our peak reproductive years, and how can it affect the perimenopause phase? I mean, like, is there any way you having an irregular period gonna make perimenopause worse and or menopause worse? Is that something that you can potentially get your cycle back on track and normal, and you can have like an easier time? I mean, how does that work? And in conjunction, does that in turn also affect our thyroid health? The more irregular your menstrual periods are, does that decline our thyroid health in general?
Yeah, it's really so individual, Alex. I mean, you have to think of like women's hormonal changes as sort of a lifelong continuum. And we each have kind of our own path that we're on. So, for folks, some folks are irregular from day one. They're never regular. Maybe they have PCO, polycystic ovary syndrome, and they never have regular cycles. Other people, maybe they're regular like clockwork once things kick in, and then they get through their 20s, and then they get into their 30s, and things start, like Mary was saying, perimenopause kind of hits, and irregular cycles kind of start hitting. And I kind of thought it was funny when Alex, you said, well, the continuum, you go from, your reproductive years to perimenopause. And honestly, you need to really realize that those overlap and that, that's a real problem, because people don't realize that they are still fertile, and you could be in the midst of perimenopause and oops, you get pregnant. Just because things are irregular or sporadic or crazy and you're having all kinds of symptoms doesn't mean you shouldn't protect yourself if you don't want to get pregnant. That's how you end up with a baby when you're 42. So, irregular cycles in general are a sign of irregular ovulation. And that happens more and more as we get older, until basically when you hit menopause, your ovaries basically conk out and you don't ovulate anymore. So that's kind of the normal progression of things. If someone has very irregular cycles, or they are skipping quite a lot, then you have a situation where they likely have estrogen dominance, like you were talking about. They ovulate so irregularly, or perhaps not at all, that you have a real imbalance between estrogen and progesterone. Because if you don't ovulate, you don't really start producing progesterone from your ovaries. I mean, when you ovulate, it produces something called the corpus luteum in your ovaries, which then produces progesterone. And then when progesterone turns off, that's what triggers your period. So if you don't ever get to that second half of the cycle, you just got ongoing estrogen. Then add in some other things like weight issues and stuff like that. It really kind of accentuates estrogen dominance, because fat cells produce estrogen too. So it ends up kind of being this, huge issue, and it presents certain risks for patients. With estrogen dominance, like Mary's saying, you can have really heavy and irregular periods, but you can end up with anemia from that. You can end up with endometrial, the lining of the uterus, like overgrowth, and even endometrial cancer from that. I mean, we pay attention to that because it matters. And then those do kind of lead into problems in menopausal years. Sometimes people continue to have estrogen dominance. They're even menopausal, but they still have too much estrogen in their system because of their weight or for whatever reason. Or they're estrogen dominant and menopause is actually delayed. Maybe they don't go through menopause till they're 55 or 56, or, and then they're at risk for all these things because of that. There can be all kinds of underlying reasons for that, but it's just really common that it happens as people get older. And then the thyroid stuff, it all gets intertwined, like we were talking about. I mean, thyroid problems become more common as we get older too. Maybe you don't have a thyroid problem when you're 35, but then when you're 50, you do, or you're 45, you do. And you have a hard time telling which symptoms are which. So that's...
Yeah, I think, like how we mentioned earlier, it's kind of just one, all intertwined, like our cycle. It's just this never ending snowball that's constantly building and building on itself. And if we don't, fix one thing in order for it to be supportive of the other, it's going to affect everything. And I think in general, we know that obviously, especially for women with thyroid conditions, we have to kind of treat and address the thyroid stuff. But what can we do, Mary, kind of from like a strategical or maybe supplemental aspect? What can we do just overall for better hormonal health? Whether, like Heather was saying, kind of what can we do to address the estrogen dominance, or what can we do to help decrease those PMS or perimenopause, symptoms that we're experiencing? So maybe hot flashes aren't so extreme, or, are there different areas that we can really like focus on and support, like our liver, for example, with detoxification and all of that? I mean, what are some, easy go-to things that we can do to just help ease this process and support our thyroid at the same time?
Sure. Well, there's actually research that came out at the end of 2022, so very recently, that talked about the factors that predict the worst perimenopausal symptoms in women with Hashimoto's and hypothyroidism. And I think looking at the factors, if these are risk factors for worse symptoms, then addressing them up front is probably going to help your perimenopause. And there's also, I'm going to go out on a limb and say the recommendations are going to help any issue related to your hormone imbalance, including your thyroid and your PMS and your perimenopause. So number one is you've got to optimize your thyroid function and manage it carefully, because if it gets out of control, if we're going for long periods of time with elevated TSH levels, we are not going to have as good results with our hormones. And that is going to contribute to worsening PMS symptoms and worsening perimenopause. We also want to look at that thyroid antibody component for Hashimoto's. And if we have high antibodies, we want to do whatever we can to get them down. We may not be able to get rid of them completely or get them dramatically different, but any lowering of antibodies reflects a lowering of the inflammation in the body. And so whether we're going to the autoimmune protocol using our Paloma app, or taking a selenium supplement, or doing something like low dose naltrexone, which we talked about in a recent speaker series, we're going to be looking in at things we can do to get those antibody levels slightly down, or even more dramatically down, because that's going to reduce the risk of having more symptomatic impact of PMS and perimenopause. We want to practice physiologic stress reduction. This is, the researchers found this was one of the biggest factors for women going into perimenopause. If you went through your 20s and 30s doing absolutely nothing to manage your stress, it's going to hit you worse than a woman who's actually practicing regular stress reduction, has her adrenals in shape, and knows how to handle the stress. So 10 minutes a day of something, I don't care whether it's breath work, prayer, meditation, a little bit of gentle yoga, whatever we're doing that's going to be an active physiologic stress reduction. And no, ladies, that's not laying on the couch watching TV. It's something that lowers our respiration, lowers our heart rate, and lowers our cortisol levels. If you're a smoker, you need to quit smoking. That's a given. There's so many hundreds of reasons for it, but it also messes with your hormones. And it also, for those of you who are smokers out there, it is associated with several years earlier onset of perimenopause and menopause. So we want to get rid of that. We want physical activity. The more active you are going into your menstrual period and your perimenopause, the less likely you are going to have some of the symptoms. And in fact, there are a lot of studies that show intensely incorporating exercise, not intense exercise, but being committed about incorporating exercise into your routine. When you go into perimenopause, you're going to have a significantly lower chance of having those vasomotor symptoms, less hot flashes, less night sweats, less cold snaps, less zapping sensations. All of those things are going to be reduced significantly due to the incorporation of exercise. You also want to get rid of or reduce your alcohol intake, because alcohol also suppresses our hormones and messes with things. and minimize your exposure to endocrine disrupting chemicals. Get rid of the flame retardant stuff, the Scotchgard spray, the nonstick pans that are not, friendly, the plastic shower curtains that outgas for 5 days and smell bad, the new car smell in your car, all those things, they are endocrine disrupting chemicals that mess with our hormones. And then finally, we want to check our magnesium levels, because magnesium has a tremendous impact on our hormone balance. And as women with hypothyroidism get older, magnesium drops. And if we can bounce it back up again, we can support our thyroid and our symptoms of PMS and perimenopause. So that's my pitch.
Well, I love that you said, Mary, you kind of like corrected yourself with the exercise, because we know that over exercising,
Right.
which
Yes.
a lot of women with thyroid conditions actually do because of the weight gain, end up actually making just in general their health worse, the cortisol spikes and all the things. So, I wouldn't say necessarily only doing gentle movement, but obviously strength training is something that we always heavily recommend to incorporate. Dr. Krantz, kind of, bouncing off of that, like what are just in general some of the strategies that maybe Mary didn't mention, or specific supplements that you have found the most success with? But also, what are markers to look for if a patient comes to you, or maybe they haven't come to you yet and they're just at home and they're just, I don't even know what to ask my doctor for. What are markers that you would suggest that they ask for, or maybe look into, and how can they come prepared, I guess you can say, to that first appointment with all of their concerns?
Okay, great. Well, with regard to supplements, I mean, it's just like a whole huge can of worms. Honestly, it's a whole separate discussion. Into you can look at botanicals that are supportive. The chaste tree berry, the black cohosh, things like that. I mean, it's just like a whole another discussion that I don't know that we have time to kind of go down that route. You can look at botanical type things. You can look at minerals and vitamins and all that kind of stuff, just like with thyroid. In terms of markers, I would generally say, when women need to obviously be screened periodically for thyroid problems with a TSH. I mean, obviously that's what we're talking about here, and at Paloma, that, we believe that is important. It's interesting because a lot of the medical associations don't particularly recommend doing that, which is unfortunate. Like I know ACOG, which is my organization, American College of OBGYN, they don't even recommend doing it with prenatal labs, which I find kind of important. I think that it's really important to be checking that, because it does affect a developing baby, and you catch stuff. The American Thyroid Association recommends screening beginning at age 35, but then they say every 5 years. Personally, I think it's such a common problem. I think we need to be screening for it. I mean, it's interesting when you look at the way they determine what normals are for labs. The reason that they're so out of whack, and that we really can't follow them very adequately, is because there were probably tons of hypothyroid people that were actually included when they did population studies. So that's why they're not very useful, and that's why they've tried to change those. And that's sort of a digression, sorry. So anyway, I think that from my own personal and professional experience, you need to check more often. I mean, I can even say, looking back at my own stuff, testing, because I'm a doctor and you do that kind of thing, I didn't see the pattern that was developing, and it's incremental. And if you could catch that, like Mary was saying, like you might be able to address somebody's Hashimoto's really early on. You can see their TSH eking up, but it's still in the normal zone. Maybe it was 2 last year and now it's 3, but still normal, that kind of thing. Other hormone tests gets honestly more complicated. Estrogen and progesterone, they're not super useful to check because they are all over the place, and the laboratory standards are very, very broad. So unless you're directing it at something in particular, like an infertility workup, or you're applying it to something like a workup of somebody who has polycystic ovary syndrome, it's not that useful. The one thing I would say is something like FSH is useful if you're trying to decide if someone's in menopause. And especially someone like maybe they don't have periods, maybe they had a hysterectomy, but they still have their ovaries. Then that's useful because it will tell you if the person's in menopause, because a lot of times they're having all these other symptoms, and maybe it's their thyroid, maybe it's something else, who knows? So that's kind of my quick and dirty thing about, women's hormones. I know we're kind of running out of time here.
Well, I think that's a perfect segue into, our live Q&A segment from our audience, because they just have so many questions when it comes to this. So as a reminder for everyone watching, if you have any questions that you would like to ask Mary or Dr. Krantz, go ahead and feel free to leave a comment on our live stream within the community, and we will be sure to, we'll try to get to as many questions as possible. But to kind of segue off of that last comment that you made, Dr. Krantz or Mary, whoever's, open to answering any of these questions, but does doing your blood test during a certain time within your cycle affect your thyroid and sex hormone lab markers? Can you kind of give us some insight maybe on when the best time is to test?
For which thing are we asking? Like for thyroid testing or for?
Yeah,
I mean, obviously, estrogen and progesterone, it matters where you are in your cycle, what you're going to get.
Right. Obviously. So I guess we can say for thyroid markers, because, since we're obviously a hypothyroid based company, is there a specific time that you would recommend you have your patients test?
I don't, because honestly.
Are there hormones going to
I
fluctuate?
don't honestly overall, I don't think it makes a huge difference. Even though we're saying that obviously, where you are in your cycle affects kind of how you feel and there's all kinds of cyclic ups and downs. I think by and large, you're looking at kind of a ongoing pattern. And I don't think that it's going to make a big difference as to where you are in your cycle as to when you check that TSH. I mean, what's your input, Mary? What do you think?
I don't know that the particular month period of your cycle matters as much for thyroid testing. I think it's and I'm more concerned, I think, with thyroid testing, that making sure people are doing it at the same time of day, so that from test to
that's
test,
a good point.
Consistency, and ideally using the same lab and same time of day, same methodology, and also making sure that they're taking their meds or not taking their meds, but they're doing it the same way each time.
That's a good point. That's a really good point.
Okay. So yeah, it definitely sounds like, thyroid maybe not so much affected by, but obviously if you're in ovulation, your estrogen is going to be much different than when you're in luteal, for example. So,
right.
Yeah.
And that's why, women often come in there in perimenopause and they're like, my hormones are out of whack. You got to check my hormones. And I'm like, yeah, it kind of doesn't work that way. It's not really going to give you useful information, unless you have like they want to check testosterone, unless you have some kind of like tumor that's producing extra testosterone. I can't tell you whether it's normal or not, especially it's like one value in time. When the breadth of normal is so broad, unless it's outside of those realms, I don't know. I'm not going to be able to tell you what's normal for you.
So to kind of continue on, we have another question. Is there any insights as to why perimenopause can last so long? Mary, I think you had mentioned it can start as early as your late 30s, all the way to, you said, for almost a decade for some women. Is there any insight as to why it can last long? And is there something that we can do to make it not?
Well, I don't know about making it not last so long, but I will tell you about something that I discovered at the time when I was going through my perimenopause and was writing my book on it. I had some sleep issues, and I started taking melatonin. And at that point, I was having the classic perimenopausal erratic menstrual cycles. I would get a period, and 2 weeks later I'd get another period. Then it would be 6 weeks, and I'd get a 10-day long period. And then the next period would last 3 days. And I was all over the place. And I had for all of my life been a 28-day, every 28 day I would have my period, and my period lasted for 5 days. It was consistent like a clock. And all of a sudden here I am with, multiple days up and down. Who knows when? It was always a mystery. When is it coming? When is it ending? I started taking melatonin for my sleeping. And like 2 months later, I noticed that my menstrual cycle had started to kind of get back on track. And so I started to do some research, and I ended up connecting with an Italian doctor named Dr. Pierpaoli, who is the leading expert on melatonin. Turns out melatonin is one of the master conductors, and it can help regulate your menstrual cycle. And it's also being used to extend fertility in some cases by fertility clinics and women that are going to all sorts of different kinds of fertility experts. So my perimenopause, which was a mess, I went on for another 2 years with cycles that were clockwork until I had a period one day, and then I never had another one. And I went through a very, very easy menopause for the most part. And I counted that the melatonin as one of the factors. And I also used Royal Maca, which is a adaptogenic hormone balancer that got rid of all my hot flashes. So I was able to go through it all naturally and not have a lot of problems with it. But I feel like the difference in the length of perimenopause probably is related to the estrogen progesterone balance in women, their melatonin levels, and all these other factors we talked about: smoking, drinking, exercise, etc.
Yeah. And I would add in, like you mentioned earlier, like estrogen disruptors and all these hormone disruptors are really probably influencing some of this. Like we see it in kids that they start cycling way earlier. I mean, even in my career of like 35 years, I can see a difference that, the onset of periods, the menarche age has gone down. And so, there are a lot of different factors involved.
I agree. I think that's something that's kind of the biggest thing that's happening right now, right? Is kids are getting their menstrual cycles young. I mean, as early as even 8 years old, I've personally seen, which is insane to me because it's like, I didn't know anything at 12 or 13 years old when I started. So I can't even imagine being, 7, 8 years old and trying to even grasp that. Mary, you had mentioned earlier some of the symptoms. This question here, you had mentioned some of the symptoms earlier. And Dr. Krantz, if you want to speak to this as well, I'm just referring to Mary's comment from earlier. But Mary had mentioned the symptoms of perimenopause, but does having hypothyroidism and or Hashimoto's actually make you at a higher risk to go into perimenopause earlier? You guys had talked about like estrogen dominance being kind of a factor in smoking and all the things, but do those specific conditions make you at higher risk to start earlier, maybe in your mid 30s versus your late 30s or mid 40s?
Hypothyroidism, straight out, no, but Hashimoto's, autoimmune diseases, sometimes are associated with earlier onset of perimenopause and the changes in the hormones. This happens with all of the different autoimmune diseases. We tend to see women having a little bit younger onset of the perimenopause. But I'd be interested in Heather's thoughts on this as well.
Well, and I would say, perimenopause, it's not like one day you wake up and you realize, oh, I'm in perimenopause. It doesn't work that way. Yeah. I mean, it's really more of a continuum.
Right.
And there are women who, like Mary was saying, who are like, oh, every 28 days, like clockwork. And then literally like the next month, things change. But that's not the usual. It's just a continuum that things gradually change over time. And some people that doesn't really happen until their cycles start getting messed up until they're in their 40s, and other people it's more in their late 30s, and maybe it's other symptoms that they have. So yeah, I don't think you can say, I agree with what Mary said, that obviously it influences it, but it's not like it's going to be the trigger.
Can you we have one question here. Can you one of you speak to the delay with menopause? I know that we're obviously not talking about menopause in general, but being that perimenopause pretty much segues into menopause, and it's that continuum that you were talking about. But you had mentioned that some women, there could be a risk associated to starting menopause extremely late. Can you talk about the risk associated with that delay?
The risk has to do with how long they go with anovulatory or almost anovulatory cycles and the higher exposure to estrogen over time. That's the risk. There's benefits to that in terms of your bones and things like that. But, and in terms of heart disease, there's a lot of good parts to that, to delayed menopause. But there are other parts that are a risk. As people start ovulating less regularly, then they're at risk for endometrial cancer, overgrowth of the lining of the uterus, that kind of stuff. A lot of this is it's influenced by so many things, but one of the things that influences is heredity. You can ask your mom, and I usually ask patients, when did your mom go through menopause? A lot of patients don't know, or their mom had a hysterectomy, whatever, but that is a piece of it. It just kind of depends. I mean, the average age is 51, but there's a spectrum all the way from like 45 to 55, basically. And everybody's got to be in there. Some people are going to be before it, and some people are going to be after it. So, yeah.
It just varies again from like person to person. I think it's already 6:01, so I just want to make sure we wrap up. We have a couple more questions here. This woman had mentioned, when I was younger, I had weight issues and lost a lot of weight twice, but I also lost my menstrual cycle twice. Can that be a sign of a thyroid problem?
Yes and no, I would say. I mean, it's not unusual when people have drastic weight changes that their cycles change. Just like girls who are anorexic, they don't get cycles. I mean, it's going to affect your hormones. Could it also be that the thyroid is part of that? It could be. It could be influencing it as well. I mean, you don't know unless you check. So you have to run the test.
Yeah. There's no downside to testing, I guess, at the end of the day. And thankfully, Paloma, we have our at-home thyroid test kit, so you can order it yourself and, monitor and see and do all the things. One last question, and then we'll go ahead and wrap up here. So I do want to make the disclaimer that at Paloma Health, we do not specialize and focus on hyperthyroidism, but I thought this question was interesting because some people can, go from hypo to hyper and kind of bounce back and forth. This woman is asking, is there a difference with hyperthyroidism versus hypothyroidism and its effect on PMS? Can having one affect your I guess, menstrual cycle differently?
That's a good question.
Well, I mean, we know with hyperthyroidism that some women will have will stop having periods when they're very hyperthyroid. So that obviously, if it's interfering with your periods to the extent that you're not having periods, that's going to affect your PMS. We do know that there is increased risk of some of the perimenopausal symptoms, not the PMS symptoms, but perimenopause symptoms with Graves' disease and hyperthyroidism. So, I mean, I think it's probably safe to assume when you have a thyroid imbalance, either direction that's not treated, it's going to impact, because it's part of the endocrine system. You're destabilizing some really intricate players that are meant to be working together. And when one thing's out of balance, it's going to throw the whole thing out of balance.
And then add in the issue that those are both autoimmune likely disorders, because women with other autoimmune disorders, they also end up with issues with periods and PMS and all that kind of stuff.
Right.
Well, thanks. I think that's it for kind of our live Q&A section. Thank you everyone so much for participating and submitting all of your questions. If you have any more questions or concerns, go ahead and feel free to leave them in the community and we'll try to get to them as much as possible. And if you aren't aware, our website, palomahealth.com, we have a plethora of resources for you, from guides and many, many blogs that Mary herself has contributed to, that you can refer to just for, educational purposes or wanting to learn more. I know we had a question here about magnesium, which we absolutely have blogs to address all of those. So if you would like to go ahead, lots of magnesium questions always. So we can, if you want to head to our blog, you can absolutely do that. And just to wrap everybody up, Dr. Krantz, where can everyone find you? And, how can they contact you if they have any questions?
Probably, for thyroid care, Paloma's the best thing. I mean, I don't practice regular OBGYN anymore because I'm turning 60 this year and I've backed away from that.
So you can head to palomahealth.com and you can book an appointment with Dr. Krantz and you can see her as your thyroid specialist. And, if you have any other things, I'm sure she can help you figure out the best treatment plan for you. And Mary, where can everybody find you and contact you? Let's say if they had any questions for you.
Well, they can find me. They can find some of my work over at the Paloma blog, where I've been doing a lot of writing there. I have a website, mary-shomon.com. I've got information about all my books there. And then I'm pretty active on social media. So you can find me at Thyroid Support on Facebook, and everywhere else I am Thyroid Mary. So.
All right, guys. Well, ladies, thank you so much. And again, for everyone attending, thank you so much for being here and just being a part of the conversation. I think in general, the biggest key takeaways from today's event is just really understanding that one, care is individualized, and we just have to look at what you're currently experiencing and addressing them there and being as preventative as possible. But also realizing that, you know, your symptoms and your experience is going to be totally different. So there isn't some, you know, one size fits all approach when it comes to just thyroid care also, but just your health in general. So, you know, that's why it's always really important for you to just be an advocate for yourself and to know and be aware. And, you know, thankfully for discussions like this, you can, you know, be more aware of what to address and what to bring to your doctor when you have your next appointment. So any other questions or concerns or resources, again, head to palomahealth.com. You can book an appointment. You can order an at-home thyroid test kit if you're wondering what, you know, your thyroid levels are. And yeah, that's basically it.